They lost the chance to prove efficacy of biglutathione by combining many endpoints which probably did not meet the criteria we talked about. So it said the addition of the extra components merely contributed to random noise, thereby diluting a potentially real effect into non-significance. So you should not go on combining everything, right? That is another message in this. I'll give you another example. When this is again by virtue of my specialty from neurology field, but it overlaps cardiology field also. That if somebody has atrial fibrillation, whether it is valvular or non-valvular, if there is high risk of thromboembolism, then we give anticoagulant. So European Society of Cardiology gives grade 1A recommendation for oral anticoagulation to prevent thromboembolism using a CHATS-BAS score which is more than or equal to 2. American Heart Association, the recommendation is also class 1 for primary stroke prevention with warfarin. And Canadian Cardiovascular Society also recommends anticoagulation for those with CHATS-BAS score more than or equal to 1. But when it comes to heart failure with reduced ejection fraction, there is controversy. Now in atrial fibrillation, you know there is stasis of the blood in the atria, so there is thrombus formation, particularly in the left atrial appendage, and that causes thromboembolism. In patients with heart failure with reduced ejection fraction, there is stasis in the left ventricle. And then there can be thrombus formation there also, and it can embolize. So why it works in, it seems to work in anticoagulation seems to work in atrial fibrillation, but in heart failure with reduced ejection fraction. See, American Heart Association says not recommend anticoagulation in patients with heart failure with reduced ejection fraction in the absence of atrial fibrillation. So if there is no atrial fibrillation, don't anticoagulate. However, European Society gives grade 2A recommendation for chronic cardiac syndrome and sinus rhythm at high risk of thromboembolism to consider dual antiplatelet or low dose rivaroxaban. American College of Chest Physicians, they recommend anticoagulation for a 3-month period following an anterior myocardial infarction and left ventricular thrombus or an ejection fraction of less than equal to 40%. Grade 2C recommendation against anticoagulation. So some gives little bit of support for anticoagulation. Some says don't give. Some says it is contraindicated. So why this type of dichotomy? And somebody did a good thing. He looked at atrial fibrillation and heart failure. All the data we combined and did a meta-analysis. And you see what he showed. This is in atrial fibrillation. Now you know that, that there is line of no difference, which is in the center. You can see this. There is a line at the center, and anything which is towards the left, if the whole line of this each trial lies to the left, it favors oral anticoagulation. If it goes to the right, it favors control, means no anticoagulation. Now if you look at atrial fibrillation, the summary is diamond. This diamond favors oral anticoagulation. When you go to heart failure with reduced ejection fraction, there are fewer studies, but quite big studies also, like 5,000, more than 5,000 subjects, for example. Here also diamond is towards the left. So there is result in favor of oral anticoagulation, both in atrial fibrillation and in heart failure with reduced ejection fraction. That is, if you take all stroke. Now the question is, you will not prevent allergic stroke by giving oral anticoagulation. So why don't we look at only ischemic stroke? Yes, ischemic stroke. Again, many studies, some big, some small. You see a diamond towards the left, which means favors if you want to see hemorrhagic stroke, which will increase with oral anticoagulation, but not statistically significant increase, which is in atrial fibrillation as well as in heart failure with reduced ejection. What if you take all-cause mortality? All-cause mortality, you have to think. If you take all causes of mortality, that oral anticoagulation is not going to prevent all the causes. Therefore, the response to this endpoint and response to ischemic stroke or myocardial infarction will be different. So, you should think whether to combine all-cause mortality or not. People take all-cause mortality because if you show effect on all-cause mortality, nobody can ask any question, right? Because you are not dissecting according to the cause of death. If you dissect, there is always a question. Was this cause of death? Was this cause of death? So, cause of death, there can be difference of opinion. But if you take all causes of death, nobody will ask any question. That is what people take. But you have to, when you take this, you have to think whether your medicine is going to have effect on this. Of course, it doesn't have much effect. Very close to line of no effect. And if you see confidence interval 0.78 to 1.08, it crosses 1, which means no statistically significant effect. Same thing for heart failure with ejection fraction, reduced ejection fraction. If you take cardiovascular mortality, there is some effect because obviously it's not easy to reduce number of deaths. There is but statistically significant effect in both. It is the confidence interval goes to 0.99, which means it doesn't cross this line of 1, which is no effect in both cases, but it is small. Myocardial infarction, yes, there is some effect, again small effect, but in both there is statistically significant. Hemorrhage will increase, there is a tendency to increase a little more in heart failure patients, but also in atrial fibrillation, not statistically significant. Fatal hemorrhage, because hemorrhage and death is so rare that it will not be statistically significant, but there is good reason to believe oral anticoagulation will cause hemorrhage. But the primary outcome which they choose with oral anticoagulation, in atrial fibrillation there is more effect as compared to heart failure. Now, why did this difference arise? This is the authors, and I agree with that. They say that we observed a major difference in the primary outcome measures employed in the trials of patients with atrial fibrillation versus heart failure with reduced ejection fraction, which have likely contributed to differing conclusions of the relative efficacy of oral anticoagulation in these two conditions. So, how the primary outcome changes the whole scenario. A key difference is that atrial fibrillation trials more often prioritize stroke in the primary outcome measures, right? So, if you look at atrial fibrillation trial, primary outcome was stroke, ischemic stroke in some stroke and other thromboembolism, but there was that was the priority and that was the primary outcome. We observed an identical magnitude of association of oral anticoagulation and stroke risk in trials of atrial fibrillation and heart failure, which permits speculation that current guideline recommendations may be different if trials of heart failure employed the same primary outcome measure as atrial fibrillation trials. So, because they took different primary outcomes, the results differed widely. And these authors, they took the same primary outcome, and when they analyzed, results are same. And these authors looked at all the trials in primary outcome, and they conclude the mortality rate in heart failure trials was considerably higher than in the atrial fibrillation trials. The reason is heart failure with reduced ejection fraction is a very serious condition. Atrial fibrillation can be just sometimes incidental detection also. So serious patients will die more often. This is not a news. And that diluted the effect, treatment effect of anticoagulation on non-fatal cardiovascular events. because if you take mortality, then mortality will be more in case of heart failure. That will add to the primary outcome. Stroke is getting reduced, but it will be diluted, as I told you in the other example of New England Journal of Medicine. So, it says that while all-cause mortality is of major clinical importance, it appears to be unaffected by oral anticoagulation. Oral anticoagulation is not going to reduce all causes of mortality. In patients with heart failure and would not satisfy this criterion for inclusion in a valid composite outcome. So this is the example I am giving you, that unless the direction of effect is similar, unless the effects are similar, you should not combine. So all-cause mortality people have combined in heart failure trials. Now why did it happen? In cardiology field, all-cause mortality is a very common endpoint, right? And because they take 30-day mortality, Dr. Prasad, am I right? And they, once they show there is a reduction of all-cause mortality, nobody asks any question, right? So it is a trend in cardiology field to take all-cause mortality. But certainly, if some trials with a smaller sample size don't take it, you need a big sample size to reduce all-cause mortality. Then what they will take? Stroke, myocardial infarction, and vascular causes of death. This is the trend.
Major adverse cardiovascular.
Or major adverse cardiovascular events. Sometimes they use PCI also. So that trend of including death is widely prevalent in cardiology. Heart failure trials were all done in cardiology. Whereas when atrial fibrillation trials were done, these obviously not for heart failure but for atrial fibrillation, they only took systemic thromboembolism and stroke. Because atrial fibrillation will cause clot there, clot will thromboembolize, and therefore it may cause stroke or it may cause systemic thromboembolism. Death was not in the primary outcome. It's certainly not all caused. So these authors conclude that based on our findings, use of oral anticoagulation would seem reasonable among patient populations who are considered at high risk of cardioembolic stroke, whether it is atrial fibrillation or it is heart failure. So this meta-analysis emphasizes that don't make you can say affected endpoints in your composite outcomes. So you should think what will be reduced by your treatment, and you should only include that. If they had done it, the same conclusions would be reached by this oral anticoagulation in heart failure as well as in atrial fibrillation. This is the point of the authors, that they messed it up by putting all-cause mortality in the primary outcome. Big trials for more than 5,000 subjects, 5,000, 6,000 subjects. But because they followed the usual trend of cardiologists, including all-cause mortality, so effect on stroke was limited.
So cause effect relationship different changes.
So yes, so randomized trial is the best way to see cause and effect relationship. So effect was not there on the death. Effect was there on stroke and to some extent on myocardial infarction. You know that the clots in the heart do not embolize to coronary arteries very often. They embolize to brain, they embolize to legs, they embolize to viscera sometimes to kidney, but not to heart so often. That is why myocardial infarction will not be reduced as much as stroke will be reduced, as much as systemic thromboembolism will be reduced. So if they took only stroke and thromboembolism, results will be same in atrial fibrillation as well as heart failure. But by combining the traditional cardiac endpoints, they messed up the whole thing.
Pathophysiology is different.
Pathophysiology is different, so affected or expected effect is different. So they did not pay much attention to these things. No? This all cardiology group sat together and thought, why not give this also, give this also. They were trying to increase the endpoints. to reduce the sample size. But that actually led to complete failure of the trial object. So you have to think a lot when you are designing a trial. What will be my primary outcome? Will it be composite outcome? If composite, then which endpoints will be combined? And that should be based on pathophysiology, that should be based on data which you have seen, that should be based on what is the mechanism of action of the drug. Sometimes it is not as clear as this. So I will tell you the example of, anyway, it talks about bleeding. Bleeding we know it will increase, but there was no significant increase in fetal hemorrhage in either population. This is what they want to say. Now, there was a trial which is called landmark trial in the field of neurology, particularly stroke, and the authors of the trial, they have written an editorial which they say how much we struggled to decide what will be our end, how will we analyze the data. So I can send you the editorial, but basically it says that we spent several sleepless nights in deciding what outcomes would be our primary. The reason is, I told you, primary outcome is the basis of sample size calculation. Primary outcome will be basis of interpretation. So if p-value goes in the other direction, then means trial has failed to demonstrate effect, right? 4 outcomes they were looking at, all very similar, but measuring different things. One measured disability. They call disability, but it is actually more than disability. So that is called Barthel index. One was to measure role limitation in society, means what they can do, what they cannot do. So 0 means they can do everything. 1 means they do everything with mild symptoms. 2 means they carry out all activities like going to for a walk or playing golf or everything. However, there are some limitations. So for example, they may not be able to cook food, but they may be able to do everything else. So one thing they are not able to do. 3 becomes they are able to walk without assistance but can't do much. So a lot of activity limitation is there. And 5th is, of course, they can't walk without assistance, so they are actually bedridden, and 6th is death. So this is called modified Rankin scale. So this was also one of the outcomes. Barthel index is about bathing, dressing, eating food, etc., etc. So that was also one of the outcomes. Then there was a Glasgow outcome scale, which is basically looking at similar thing as modified Rankin scale, but it is used by neurosurgeons more for head injury patients. But that also classified people. That was also one of the outcome measure. And then NIH stroke scale, which looks at what is the grade of weakness, whether you have visual field defect, whether your speech is affected, what is the level of sensorium. So we call it neurological deficits. So one is measuring neurological deficit, one is measuring disability, and 2 are measuring larger role in society. So they said, which one we keep primary? Very difficult to decide. If we take, let us say that time trend was Barthel index. And suppose it doesn't come significant, but modified Rankin scale comes out significant, then what will be? We have chosen something which did not come out statistically significant. So our trial will be told to have failed to demonstrate effect of tissue plasma activator in ischemic stroke. So after a lot of deliberation, all experts were sitting in NIH, and they said we discussed for days and days, but we could not arrive at any conclusion, because our problem was, and sleepless night was, because if we take this one and that one doesn't turn out to be significant, the other one turns out to be significant, then we will have to at the sorry figure. So why not? We avoid selecting it. So finally they decided we will not select one of them as primary. So the advice from statisticians was that you use a global statistical analysis, which means if anyone is turning out to be significant, the others are in the same direction, we will call the trial as positive. So if you read it, there is no primary endpoint which is decided, but they decided primary analysis will be global statistical analysis. They decided not to choose any one of these four as primary endpoint because they could not decide. So imagine this can be as serious as this. And this was illustrated in what is called stitch trial. This is a trial of surgery in brain hemorrhage. And they chose Glasgow outcome scale because neurosurgeon was the primary principal investigator. So you know they like Glasgow outcome scale. Glasgow coma scale for assessment in the beginning and outcome scale, Glasgow outcome scale for assessment of the endpoint. So Glasgow outcome scale was their primary outcome. It all goes on tradition. You see, the neurosurgeons have a tradition to take Glasgow outcome scale, so they feel much more comfortable with choosing that. That did not turn out to be significant, but modified ranking scale turned out to be statistically significant. So the author, who is a friend of mine, and we met several times, I tell you, he repents so much that we did not take modified ranking scale as our primary outcome. So he says, we forgot that this is a neurological condition. We should have taken what is the favorite endpoint for the neurology group, which is modified ranking scale. We took Glasgow outcome scale, and I'm sure he has lost sleep nights after nights on why he did this. So choosing a primary endpoint is a very, very important consideration, and you should spend a lot of time in thinking about that. This is why I have spent almost 3 days on endpoints. But those who want to do a relatively smaller sample size study in a single center, think of a continuous outcome, which nobody can deny, like hemoglobin A1C. If you reduce hemoglobin A1C by some treatment or some new treatment or some new method or by some like yoga or maybe even putting SMS reminder, nobody will challenge it because it is well accepted, biomarker. Similarly, if you do something to, say, reduce cholesterol, nobody is going to challenge that because it is a very well established endpoint. If you reduce blood pressure, these are all numbers. They don't fall in this category of endpoint. They are not dichotomous or binary yes, no kind of thing. We discussed that outcomes can be dichotomous, outcome can be ranked outcome, it can be no, I said that in your I haven't told them about this group now. That you can have ranked categories or two categories is binary dichotomous, or you may have numerical continuous outcome like HbA1c or cholesterol or blood pressure. Blood pressure, if you reduce by any means, whether it is yoga, meditation, some kind of new treatment, nobody is going to challenge it. So take continuous outcome. A smaller sample size will be required, but if you want to get some kind of approval based on this, it will be difficult because the regulatory agencies want to see effect on clinical end. And that is why pioglitazone study, they wanted to show that clinical endpoints are affected. They could have done it on HbA1c, which I am sure must have got reduced. This was one of the few trials. Bioglucogen was later on approved, but that trial, proactive trial, they actually didn't get a statistical significance, so they had to do another trial. And each trial, for many of you would like to do it, takes a lot of your time and energy. So better to focus on something where you are likely to convince the clinical community to do what you intend them to do. So you should know what is your clinical community like. What will convince people to change their approach. So take that as the outcome. And that may be not easy, but it is good to discuss with your colleagues that this is the outcome which we are going to take. So I told you 3 days discussion in NIH to decide which primary outcome we should take, and they could not reach a conclusion. So it is a very serious business, and therefore end point is a very crucial thing, and you should think a lot about that. And I told you that it doesn't matter much in phase 2 study or phase 1 study, because that is not a pivotal study, that is not a definitive study. Definitive study is phase 3. Therefore, you have to do a lot of thinking how to plan phase 3. Any question?
But some outcomes, the clinical outcomes you may not, such they are very difficult to measure, and you tend to get into some continuous variables. Right? Like suppose I want to take inflammatory measures where I cannot. Can we do that, or it's still a
So you have to ask yourself which inflammatory measure, if reduced, will convince the clinical community to adopt your intervention. Your idea is to convince people to adopt your intervention if it is efficacious, right? So if you think this will, your D-dimer, for example, is going to convince people to change their approach of treatment, then you take that. That is not a problem. But, and also for phase 2 trial, not a problem. But if you want to do phase 3 trial, which will enter into guidelines, means guidelines will change, guidelines to management will change based on your study, then you have to take such endpoints which will convince the community, because guidelines are made by clinical community experts. They should be convinced that yes, this is important thing to do. But if D-dimer decreases, but mortality increases, then nobody will be convinced. So I told you one example that enkenide, flecainide are antiarrhythmic drugs. So after heart attack, if you give, arrhythmia will be less. People know that arrhythmia is the major cause of death in myocardial infarction. When they did a trial, phase 2 trial, arrhythmias were decreased. So phase 3 trial was conducted, but that was with mortality as well. And it went in another direction. Mortality was more if this drug was given. So the question is, why did it happen? It happened because we don't know everything which a drug does to the body. You will never know. And therefore, probably it does something to the heart which is other than arrhythmia, which may cause death. So it never got approval. No, but it is cited as a good example of why surrogate outcomes or intermediate outcomes, or you can say outcomes which are not clinically meaningful or significant, are taken, but that will not allow the drug to come to market. It has to be a clinical endpoint. So that was another reason why this stroke medicine with DCGI, this company was trying to push, did not pass. That endpoints was not clinical. Or even if it was clinical, they didn't analyze it that way. So there were many reasons why we did not get approval. But yes, you can take surrogate outcomes. This will be called surrogate outcomes. We discussed one day, no? Surrogate outcomes. Surrogate outcomes are okay if they meet certain criteria. Now, one is that surrogate outcome should be strongly correlated with clinical outcome. Like blood pressure strongly correlates with heart attack, stroke, and vascular causes of death. Right? So, blood pressure is a good surrogate outcome. And secondly, at least in some trials, it would have been shown that reduction of blood pressure is associated with reduction of death. So there should be at least some randomized trial where blood pressure was an endpoint, but mortality or stroke or MI was also an endpoint. And when the BP was reduced, there was a reduction in MI or stroke, and so previous randomized trials should have established this. And if it is with one class of drugs, for example, let's say beta blocker, then still there will be question, because beta blocker may be causing reduction of pressure, but may also be affecting rhythm of the heart and reducing mortality. But we are only looking at BP reduction, so we may be mistaken. But if another class of drug, let's say calcium channel blocker, right, amlodipine or something, that also shows that the reduction in blood pressure and reduction in death, stroke, or myocardial infarction. That means it is the blood pressure which is responsible, right? Because amlodipine will not have the same effect on rhythm as beta blocker. So it is not the rhythm which is affecting, it is the BP reduction which is affecting. So if two classes of drugs show similar correlation between surrogate outcome and clinical outcome, then no questions are. So three criteria. No? One, there should be consistent, strong, and independent relationship between the surrogate outcome and clinical outcome. Number one. Number two, in some randomized trial at least, with one class of drugs, there should have been correlation between reduction of surrogate outcome and reduction of clinical outcomes. Three, with different classes of drugs, same correlation between surrogate outcome and clinical outcome should have been observed. If these three criteria are satisfied, that surrogate outcome is accepted, no problem. But only in observational studies, which is common, if you show this, this will not be very good surrogate. That doesn't mean you can't do it. You can do phase 2 studies with surrogate outcome. Even studies which you want to do in one center, if you do this, and you think it will convince people to at least acknowledge that there is something in this treatment, you should do it. I'm not saying don't do it, but the point I am making is you should see how strongly it correlates. Like Glasgow Coma Scale is well established. So in one of the discussion, I asked, why don't we take Glasgow Coma Scale as our outcome? If Glasgow Coma Scale improves, then the treatment is good. So the same question was asked. Is there a randomized trial which shows that improvement in Glasgow Coma Scale is associated with increase in survival? Then let us see that. And secondly, has it been reproduced by different types of interventions? If these criteria are fulfilled, these three criteria, strong and consistent independent relationship with clinical outcome, in one randomized trial at least, the two have been shown to correlate. In trials of different interventions also it has been shown to correlate, then it will be accepted. When I started looking at the data, it is not happening. So nobody takes Glasgow Coma Scale as end point. Remember, Glasgow Coma Scale is a must for baseline assessment of the patient.
Can it be considered as a continuous outcome kind of thing?
If it was accepted as an outcome, then nobody has accepted it as an outcome. It is unavoidable for assessing patient and deciding severity of the disease. Right? No question asked about that. In fact, you must do it if you are doing any study. study with brain involvement. Like I had data of Japanese encephalitis from Gorakhpur. Some doctors came to me that we have data of 5,000 or some other subjects. But we are not able to write any paper. What we are writing is not getting accepted. So I looked at the data. I said, you don't have even Glasgow scale. So if you have not measured Glasgow scale at the time of admission of these children, then who will accept this paper? So you must measure everything which is important. But that will not be an end point. It will be baseline assessment to define severity. That you must do. That is a different thing. But end point must meet certain criteria.
Some endpoints like psychiatric outcomes are difficult and they are so subjective. So what
Remission of depression, for example, is a good endpoint. Remission. Cognitive scales are taken in Alzheimer's disease as endpoints. In fact, one of the famous one is ADAS-COG, as it is called. Alzheimer's Disease Association has developed a cognitive scale, which people take. Now, the problem which, of course, companies were very smart to bypass this was that they analyze it as continuous variable. But there were always questions asked that you must show it improvement in activities of daily living. When activities of daily living was shown to improve, then only regulatory authorities approved it. So all the drugs which came to the market, they had to show that activities of daily living improve. That is a clinical outcome. Scales is basically what your scientists measure. The patient doesn't know about that, patient doesn't feel about that. So your COG scale increases by 2 points. It is the same. Then the regulatory authorities are not going to approve. So you have to have clinically significant endpoint. So that is why they had to demonstrate that activities of daily living change. Means people become more independent in activities of daily living. Even if 2 activities of daily living, it is okay. Persons who are totally dependent on dressing or eating, now they are independent. Yes, that is a benefit to the patient. It is visible to the patient. So another word has come, patient reported outcomes, PRO. Right? What the patient reports is more important, not what your lab reports. So that is, there is a movement towards patient reported outcomes.
Sometimes placebos do act.
Yeah, that's it. So that if you have randomized trial, it will happen in both the groups, na? So it will be balanced.
So why is there, like in critical cases, most of the studies, 28 days mortality. Well, why is it that it has been fixed as 28 days mortality or 90 days mortality? I fail to understand. What is the C? Why not 30 days? Why not 25 days? Why it is 28 days mortality?
lunar cycle.
So some decisions are arbitrary, but again I told you, you have to see what the clinical community thinks. So if the clinical community is convinced about that, right, it happens arbitrarily, but once it becomes a culture, then everybody accepts it. So I told you that you have to know the culture of the field. So before you start any study, you must go into details of the literature. And I ask my residents, you can ask your residents, that if you are going to do clinical study, any clinical study, you first make a table. That table should have study, reference or whatever. It should have inclusion exclusion criteria. It should have primary outcome. It should have secondary. Make a table. If you make a table, you will know what is the culture of your. So it depends on the culture also. Culture changes also with time. But I have seen when I started neurology, Barthel index was more commonly taken endpoint in stroke. Now it has changed to modified Rankin scale. So when we did the stroke stem cell study, we took both. And we were asked this question, why have you taken Barthel index? Modified Rankin scale is most widely accepted endpoint. So I had to reply that you are forgetting what used to happen earlier. Barthel index was the most commonly used endpoint. Now it has changed, so we have taken both. Any other question? Right. So I wanted to start consort guidelines, but should we do that? I think what I have not done is sample size calculation for observational studies. We did for randomized trials, right? So what would you prefer? Sample size for observational studies, or maybe first we should know what are the observational study designs. So next time we will do study.
So last class there was a discussion that we should start having some discussion on what are new ideas.
Right.
Last class you said.
It depends on people who.
First,
there are different departments here, so you should take something which is common for everyone. So we will take study design.
No, first sir, the sample size calculation and because most of the time we are doing only that only, observational studies. It's difficult to do randomized
Control
trials.
Not difficult.
Not difficult, but planning and other.
I used to think so, but when I went to Canada, so Dave Sackett was head of the department. No, he had just moved out as there is 5 years tenure for head of the department also. So after 2 tenures, he moved out as head of the department because he wanted to spend more time in research. So he used to tell, just to I think also inspire people, that you give me a problem and I will give you randomized trial design. There is no problem which is not amenable to randomized trial. When I entered that building, I used to think randomized trials are only for few things, right? And again, high cost and this and that. He says, but he used to say that if I have to do something, I will do randomized trial. And observational studies within the randomized trial. Right? After all, control group is observational study, right? So he used to say that don't do observational studies. Do a randomized trial, and in that you can do observational study also, right? So we said, what about diagnostic test? He says, we can do randomized trial of diagnostic test. What is the problem? Right? So he says, why do you do diagnostic test? You want to give confidence to the physician that diagnosis is correct. You want to improve compliance of the patient so that they know that diagnosis is confirmed. So they will take the drug like tuberculosis. So why don't you measure those things? Right? So, but how will you do blinding? This is what is the problem? We will reveal the diagnostic test result to one group, one arm, and don't reveal it to another arm. Right? Right? Then see what is the difference in the confidence of the physicians, patient's behavior, and so on. I said, but it will be unethical. What is unethical when they see a new diagnostic test? And people have been practicing without the result of the diagnostic test. So if we do a study to establish its benefit, why it is unethical? He said, but you are hiding the results, patient may be harmed. You have a data safety monitoring committee. So they will be looking unblinded result. They will know test result of every patient. And in confidence they will monitor. So if there is any harm going on, that is also a good finding. You should stop the trial and say, forget this diagnostic test. Right? So he said, everything which you do, and sometime I will tell you in education also, he said, everything in education you do can be subjected to randomized trial. So he was a very strong proponent of randomized trials, and I saw that because of his conviction, everybody was doing a randomized trial in that building. Right? And major trials, which get published only in Lancet and New England Journal of Medicine. So you should be that kind of head of the department, that you should inspire people to do something which gets to the top.
So that depends on ethics committee also.
Ethics committee is a problem, that they also face. So the Canadian researcher, Gordon Guy, who is now very famous also, he said, ethics of the ethics committee should be examined. Right? Thank you.